Hi, my name is Monica Chang, and I'm a fourth-year medical student going into diagnostic radiology. Today, as a part of the Step 1 and Clerkship preparation course, I will be presenting to you a guide on how to read a chest x-ray, a clerkship primer for medical students. A variety of imaging modalities exist. Broadly speaking, we can categorize them based on whether ionizing radiation is used or not. In this PowerPoint, we're going to go and focus on radiography, or x-rays. Wilhelm Röntgen discovered X-rays in 1895 accidentally while testing whether cathode rays could pass through glass. Shortly after his discovery, he took a radiograph of his wife's hand, and when she saw her skeleton, she exclaimed, "I have seen my death." Röntgen called the rays X, meaning unknown, and won the first Nobel Prize in Physics in 1901 for his discovery. X-rays work by transmitting an external beam of radiation at the patient to the detector on the other side. Structures that appear radiopaque or white on imaging have greater density and resist the passage of X-rays. Conversely, structures that appear radiolucent or black on imaging have less density and permit the X-ray beam to pass through them. The advantage to X-rays or radiographs is that they are relatively fast, inexpensive, and have less radiation exposure compared to CT and other imaging modalities. Next, we will discuss the different views available on chest x-ray. The standard chest exam consists of a PA, or posterior anterior, and lateral chest x-ray, and these two films are usually read together. The PA exam is viewed as if the patient is standing in front of you with their right side on your left. On lateral view, you'll notice that the spine should appear to darken as you move caudally because there's more air in the lower lobes of the lung. Another important point is that the image should always be taken at full inspiration so that the cardiothoracic cavity can be fully visualized. The lateral decubitus view is helpful for assessing the volume of pleural effusion to determine if it's mobile or loculated. Here, the patient is positioned lying on the right side, and the right lateral decubitus view shows a mobile pleural effusion in the right lung that forms a fluid level. The PA, or posterior anterior film, is obtained with the patient facing the detector, so the heart is further away from the X-ray emitting tube. And this is the preferred view because it diminishes the effect of beam divergence and magnification of structures closer to the X-ray tube. The AP film is also known as the portable chest x-ray and typically is obtained for critically ill patients who can't stand upright. Because the heart is closer to the x-ray tube, there is magnification of the heart and widening of the mediastinum that's just good to keep in mind when you're viewing an AP film. I just want to point out the basic anatomic structures that are helpful for a medical student level. Primarily, I want you to take note of the aortic arch, diaphragms, and left ventricle and right atrium, which form the right and left heart borders, which will become important as we go over some examples of classic pathologies. You'll also notice the right diaphragm is usually slightly more elevated than the left diaphragm because of the location of the liver just beneath. I also wanted to briefly point out the lung margins, which are useful for describing various pathologies like pneumonia. You'll notice that the left lung has only 2 lobes and a lingula, while the right lung has 3 main lobes. Now I'm going to go over the ABC approach to reading a chest x-ray. I want to acknowledge that there are many different approaches to this, but the important thing is that you develop a systematic search pattern that you can stick with that covers all the bases. I also want to mention that it may seem obvious, but before you start examining the image, it's important to confirm that you're looking at the right image. So take note of the patient's name, date of birth, and date of imaging, which should be located on the upper left-hand corner of every image. The image should also label the technique that's used, such as AP or PA, supine, lateral decubitus, etc., and whether contrast or whatever is used. So let's begin without further ado. So first, we'll take a look at the airway. Trace down the trachea to the carina. Is it straight and midline? Is there any narrowing? Now you'll trace down both main bronchi. Is the carina wide or greater than 100 degrees? And is there bronchial narrowing or cutoff? Is there any inhaled foreign body? Next is B for breathing. Here we're looking for lung and pleural pathology. Both lungs should be well expanded and similar in volume. Can you count 10 posterior ribs bilaterally? Is one lung larger than the other? Next, you'll compare the apical, upper, middle, and lower zones in turn. Are they symmetric? Are there any areas of increased density? Continuing on. So, trace the lateral margins of the lung to the costophrenic angles. Are the costophrenic angles crisp? Now trace the hemidiaphragms into the vertebrae. Can you see the whole of the hemidiaphragm? Then trace the cardiac borders. Can you clearly define the left and right heart borders? Now we're on C for circulation. So we want to check the cardiac position. Is the heart located 1/3 to the right of midline and 2/3 to the left? We also want to assess cardiac size. Is the cardiothoracic ratio less than 50%? And then finally, check the width of the upper mediastinum to rule out pathologies like aortic dissection. Next, we will discuss D for disability. This can encompass various bony pathologies such as fracture or metastasis. You'll want to trace along the posterior rib on each side of the chest to assess for fracture or any abnormal area. Check the clavicles and shoulders. Can you trace around the cortex of the bones? And then check the vertebral bodies. Are they all rectangular and similar in length? My question to you now is, can you detect the bony abnormality in this chest x-ray? So the answer is, this image shows multiple left rib fractures as demonstrated by the red arrows. And this is consistent with flailed chest, where the rib cage now moves paradoxically inward with inspiration. E is for everything else. You'll want to examine the diaphragm for free air or pneumoperitoneum, which this image shows. Check the mediastinal contours, including the heart, great vessels, and lymphoid tissue. Any soft tissue abnormalities like large hematoma, and then tubes, valves, and pacemakers. Again. Now that we've gone over the ABC's approach to reading a chest x-ray, we'll now go over some classic pathologies. This is a 19-year-old male with shortness of breath and cough. He had chest x-ray taken with PA and lateral views. The main finding here is opacification of the right middle lobe, which you'll notice obscures the right heart border, creating the classic silhouette sign suggestive of pneumonia. Pneumonia is an airspace disease with consolidation. Its characteristic patterns on chest x-ray include lobar, interstitial, and aspiration. Here's a different case. Going through your ABCs, what do you notice? First of all, tracing down the trachea, you'll notice deviation of the mediastinal structures to the left, as well as darkening of the right lung, where you can see the outline of the lung, which has collapsed completely. This is a severe case of tension pneumothorax with contralateral mediastinal shift and a classic deep sulcus sign, where air collects in the inferior sulci of the lungs adjacent to the diaphragms. This patient will require needle thoracostomy or chest tube as soon as possible to avoid life-threatening hemodynamic compromise. Here's the deep sulcus, and here's the outline of the pleura. Pneumothorax is defined as air in the thoracic cavity but outside the lung. The most common cause is iatrogenic, such as during surgery or central line placement. Trauma, such as motor vehicle accident, is another common cause. I've listed some other potential causes below, and as we have learned, the classic imaging finding is the deep sulcus sign. Here's a different case. As you go through the ABCs, you'll notice as you get to the diaphragm, there is blunting of the costophrenic angles bilaterally, with a concave meniscal look to it. This is consistent with bilateral pleural effusion. Pleural effusion, as you know, can be classified as exudative or transudative according to the Lights criteria. The common causes include congestive heart failure, malignancy, renal failure, and more. On an upright film, an effusion can cause blunting of the costophrenic angle and potentially mediastinal shift away from the effusion. Approximately 200 mL of fluid is needed to detect the pleural effusion on the frontal film, while 75 mL is required for detection on the lateral film. Interestingly, large unilateral effusions are more likely to be caused by malignancy, and ultrasound is also a key component for diagnosis and can guide aspiration of small effusions. Now we'll go over a couple classic but challenging board review questions that are representative of the style you may encounter in step 2. This is a 78-year-old male with a history of hypertension, diabetes, and hypercholesterolemia who presents to the ED with a syncope episode after experiencing chest and neck pain. EKG shows sinus tachycardia with evidence of left ventricular hypertrophy. What is the next best step for working up this patient's condition? Given the clinical context of an elderly male with cardiovascular disease risk factors and clinical symptoms of syncope after chest and neck pain, there's a high clinical suspicion for aortic dissection. And when you look at the imaging, you'll notice mediastinal widening. If the patient is hemodynamically stable, meaning they have vital signs that are within normal limits relatively, then CT angiography or CTA is the appropriate next step. But if the patient is non-hemodynamically stable, then echo is the next best step. Next question. We have an 18-month-old patient who arrives in the ED in respiratory distress with severe coughing and wheezing starting an hour ago. These symptoms are refractory to albuterol and supplementary oxygen. Physical exam revealed prolonged expiratory phase and wheezing, as well as hyperresonance of the right lung. What is the diagnosis of this patient? Given the fact that the patient is wheezing and not responding to albuterol and supplementary oxygen, it's unlikely that the patient has an asthma exacerbation. Looking at the imaging, you'll notice that the trachea is not midline, but rather deviated to the left, away from the affected lung, which looks hyperexpanded and radiolucent. This is a classic presentation for foreign body aspiration down the right main bronchus in this young patient. The reason why it's not pneumothorax is because you'd see lung collapse rather than hyperinflation, and wheezing is not a typical symptom of pneumothorax. Thank you so much for listening to my presentation, and I hope this has been a helpful guide for priming you on the classic ABC method for reading a chest x-ray and how to identify the major signs of some classic pathologies seen on radiography.